small missions that were sent to the interior and then in this river. They found this girl who was being carried around by her mother, and she came to the doctor's camp and put her down there and said that she's going to die. What do you want me to do with her? And as things go, she was brought to the city of light. On me? And she was brought to the city of light, and we said that people say that you say things and you say why, and sometimes you dream and say why not. And then she got operated at a private institution at the Aga Khan. We did a tetralogy of fellow repair. Her saturation pre-operatively was 45%. And this is her a day after surgery, and then a year, and recently she's married 2 years ago and has delivered a normal child. And then that got us thinking that what are we here for? We have been trained, and then what are we going to do? So we developed this Mending Kids' Hearts while in AKU, and it resonates throughout the country. It's not just specific to AKU. It's every one of us thinks the same, that every child born anywhere with a congenital heart disease should have access to appropriate medical and surgical care. And it also states to develop an environment conducive for training, education, and research, and produce future leaders in pediatric cardiac services. That's the ethos of all of us, or should be. Then a 4-week-old neonate from Balochistan is referred. He's the first born after 4 years. He's brought to the ER, PO2 about 55%. He's done an echo which shows DTGA with an intact ventricular septum and a small PFO, and a small ASD. He's got no finances, and he's been referred to the welfare. And he before surgery, is saying that an essential aspect of creativity is not being afraid to fail. Sometimes we get timid and we are afraid of failure. But that does not mean that we have a bravado approach to life. We need to have a sensible and measured approach to life. Anyway, he underwent an arterial switch operation, and when he was shifted to the ICU, he arrested. His chest was already open, so we did an open cardiac massage. And while doing that, shifted him back to OR, and we put him on an VA ECMO through the neck. This was possible because we had Mr. Asif Hassan at that day, with us, unplanned. But he said that, let's do it. This is the only way that you're going to save the child. And he was discontinued after 72 hours. His chest was closed on day 5, and the patient went home day 10, and he's a normal, healthy child at 1 year, and now it's been like about 11 years since surgery. This was the first successful ECMO in a neonate in Pakistan, and this was reported and published. This is the team. Out of this team, you can see Babar there, and Nadeem, he's a pediatric cardiologist now at SIUT. Sometimes we do something which is, very rare, and then we keep doing it and it becomes the norm. And we as pediatric cardiac surgeons, the country over, have achieved that. Before, if you go 20 years from now, doing a tetralogy was a big achievement. Now, doing a tetralogy is run-of-the-mill because it's being done every day, maybe twice a day in a center, or maybe 4 in a center. And then you cross all boundaries. You test yourself and you start operating on smaller and smaller kids. But as congenital cardiac surgeons, we have the capacity and the training and the philosophy that we can operate on anyone of any age, of any weight, so that we can correct them. And this is a baby which weighed 680 grams, and you can see the size. It's smaller, nearly as small as a hand, and certainly heavier than a puppy who had a PDA and needed PDA ligation. And as it goes, that you don't stop golfing when you get old. Salman? You get old when you stop golfing. Yeah? And this gentleman was 78 years old when he came to us for repair of tetralogy of fellow. And we said, why are you doing that? Well, so he said that I cannot complete my 9 holes of golf. And if I can't do that, there's no point in life. So we operated, and he's now doing 18 holes. So the time has come when we decide whether we will continue to be part of a problem or we are going to solve it. And I think we have come a long way and solved it to a major extent. But still 90% of the children in the world with congenital heart disease do not receive or receive suboptimal support. Still in Pakistan we are lagging behind. If we are conservative and say that we are doing about, say, if we very, very extravagant and say we are doing 10,000 cases in the country, and we are still producing 50,000 children with congenital heart disease each year. So we're still running short of 40,000. And it is a burden that is going into the millions. So how do you train? And this is by my mentor and a mentor of a few of us in this room. There are 3 ways of learning. But what we need to take take-home message from this is that surgeon should avoid performing a procedure beyond his competence. And yes, you can push the boundary, but be sensible about it. Have support or learn them. And it's been, and you can visit and observe established surgeons. Some of us may learn from that way. Establish specifically designed courses. They're very, very expensive. You need a designer for it and a proctor for it. Better still is to invite the established surgeon to help you develop a certain program or a procedure. And I've put an asterisk there. And that is what we have learned, and that is what the journey that I'm going to talk about, is that it is not just surgery, but it is the whole team which makes a difference. So when you want to develop or progress from what you are, at what stage you are, instead of developing just the surgical expertise, you need to take into account of developing your other facilities, your cardiologist, your intensivist, your nursing staff, your OR staff, your perfusion sciences. All of that has to be taken into account. Because a surgeon may learn something which is so advanced that the team is unaware or not trained. So when you are going to progress, you need to train the whole team, not a person. So this is from Nishan, but I think this is what the ethos of our institution, SIUT, is through Adib Rizvi, that he thinks that nothing is impossible, and most of the things he's been able to achieve is because of this thought. This was the first mission ever done by any Pakistani pediatric cardiac team, and this was a mission to Kabul in 2008. Babar is not in this picture, but he was certainly there. So we thought, oh, this wonderful opportunity, yeah? We are going to go to a war-torn country, we will be saviors. They will be welcoming us with open arms. Everybody will be willing to learn from us. We are such a fantastic team. We were 8 of us, perfusionists, cardiologists, nursing, OR staff, everyone was there. But when we went there, we found they didn't love us. They were resistant to change. And they always considered us not to be a very friendly country. Strange. But that's the reality. But we went and we operated and we taught and we did echoes and we did intervention and we did nursing and we did perfusion with them. And this is, I'm doing a Tautology of Fellow repair. And during that repair, I am told that we have to evacuate because this was happening. It normally takes 40 minutes from where we were operating to the airport. On that day, it took us 5 hours and 11 checkposts. But we were back the next year and the year after. We did not give up. We did 4 missions. We provided service not just to cardiac surgery, but to cardiology, developed their echo techniques, their echo reporting. What are we specifically looking at in echoes from a surgical point of view? They're outpatients, education and training at all levels. So a mission's job is not to do an operation. A mission's job is to educate them and develop them. And the last mission that we did, we saw acceptance. This was the last team that went, and we have got, people may recognize, Dr. Mubashir over there. I also did a small mission to Maldives, nice place. Anyone who's not unmarried, after they get married, or when they intend to get married, they can go there. Fantastic place. And all those who are married need to go there so that you stay married. Then came Mission Najaf. Now this was a different ball game. It had been in a war, but it was now safe. But we had been bitten before. So this time our approach was different. We wanted to be invited and not imposed. Primarily, we went and met them. We did not take a mission. It was just myself, Dr. Babar, and our intensivist who went, saw the place, met people, told them what we want to do. We did not want anything in return. There were teams coming from India, there were teams coming from US. They were doing procedures, many more than what we were doing, but they were charging and they were not teaching. We said, we don't charge, but we want to teach. And we want to teach at all levels. And we set out with developing trust between the two units. We developed human capacity towards independence. We wanted to make them independently do operations, procedures, take care of the patients in the ICU. And we wanted to provide service to the people to the children of Iraq. But the bottom line remains train and educate. That is mission. Doing a procedure is not a mission. Training and educating is the mission. Now, obviously, we went to the Karbala and Hazrat Ali's shrine. And this was our team, first team, second team, and people might notice her and her. And she's there again, right? Yeah, that's you. And that Ayman is sitting over there at the back. She's been integral part of the team from the beginning. So this was a Glenn shunt we did, who wanted to die. Ayman stayed with the patient till the patient went home. That's why we took Ayman. That's Babar doing TOFs, echoes, not TOFs. And that's our intensivist with a miracle baby who also was actually dead when we were doing rounds, and we revived him and he sent home. But what we have done has been capacity building at all levels. Each one of us involved. I'm taking their surgeon through a Tautology of Fellow repair. And you can just see Ayman peeking in from there. We planned out surgeries, we looked at all the equipment, every day it was the same. It wasn't that we will do it one day, every day it would be the same. And then it was time to say farewell. But we did deliver. And there's actually the video doesn't play, but it does say that this was a small kid that we did a coarctation of aorta repair, and he sent his salams, and that's Lake in Najaf. So what did we achieve from the Najaf mission? We were from non-acceptance to appreciation, from aloofness to integration, from dependence to independence. They're now doing VSDs and some TOFs and ASDs and sinus stenosis type and Glenn shunts on their own. And both teams are looking forward to the next mission, which will be our 6th mission in early next year. So in conclusion, congenital heart disease is and remains a challenge in Pakistan, Afghanistan, and Iraq. Proper planning and implementation of phased programs will have good results, and results will always need to be improved. So if you are, for example, tetralogy of fellow mortality is 5%, you want to bring it down to 2%. If it's 2%, you want to bring it down to 1%. Right? So your bar will keep changing with time and progression. And you have to keep collaborating to improve outcomes. And to answer Asim's question, I think this is important. Be invited rather than say that, oh, we want to come and do a mission. And Pakistan has got a lot of centers which are in the developing phase. And there are people here in this room who can contribute to that development further. And so speed up the process. It's not imposing, it's helping. But that has to be understood. And that is our mentor for life, unfortunately for him. So don't be afraid of change, of new ideas. Be afraid of old ideas. They keep you where you are and stop you from growing and moving forward. Concentrate on where you want to go, not on what you fear. That is our problem, that we fear. Pakistan Zindabad.
For that wonderful talk, and thank you also for sticking right on time. We're going to move on to our next speaker, Dr. Daud Kamal, who will be talking to us about international training and its impact on local institutions. We'll do questions at the end of our 3 talks for this part of the session.
कौन सा नहीं ठीक है वैसे पॉइंटर तो है ना ठीक Bismillahirrahmanirrahim. A small community, I hope we all know each other. I was given a topic and it's quite connected to what Dr. Munir just mentioned. So I'm going to talk about experience in terms of what my institute in general and me and my other surgeon who is not here today, that how it impacted us in terms of the quality and outcome. So I'm going to talk about international training and its impact on local institution. So when I was given this topic by Dr. Munir, I was just thinking that how we should define. So I had to fragment this into 2 parts. A was, how do you define international training? And second is, how do you define impact on local institute? So in international training, there were 2 things which came to my mind, and actually both of these components actually followed into our training system. One is that international master trainers, they visit AFIC or any local institute, and what impact they create on that institute. And second is that we, the local fellows, I mean, the fellows which have been trained primarily in Pakistan, they go outside and they actually get a foreign exposure, and how much they actually change into their institute. So then coming to how do you define the impact on institutes, so it's pretty simple for me. I think one, that you introduce something new to the system which was not there before, and second is that you improve on whatever is already happening in the system. So my talk will be actually encompassing all these four things, that how international program which has been coming to FIC, how it changed FIC, and how the fellows from FIC who've been going abroad for fellowships, what did they do to their center in terms of results and variety of procedures. So the first and the longest mission FIC ever had was with Dr. William Novick. I think most of you know him. He was previously working with International Children's Heart Foundation from US, and now he runs his own mission by name of Cardiac Alliance. So we visited AFIC. I mean, I was never been part of these training missions. I was even not in AFIC at that time, but he has been visiting AFIC between 2006 to 2009, and they used to visit quarterly for 2 weeks. They would stay here, and they almost made 15 visits to AFIC during these four years' time. And as Dr. Munir mentioned, that the advantage of this mission was that it was not just focusing on the surgeon. Like, if you have to develop a system, it's not just that a surgeon learns a new skill. You have to actually focus on all the components of the medical healthcare. So surgeons, cardiologists, intensivists, perfusionists, theater and ICU team. So he would actually come with a team of 10, 12 people who would actually focus on every component of the healthcare system. So, and this is a picture, I think it is somewhere in 2007, 2008. Most of them have retired now. None of them, I think, very few would be still serving, people living in this picture. But actually, this program gave FIC a dedicated pediatric cardiac center in a very running condition. And then we had the sporadic visits. Of course, on the top is Dr. Hassan. He made 3 visits. I think in early 2000, then in 2015, and then recent 2021. Then Professor Zuhair Al-Alis, he made 2 visits to FIC. David Anderson from Evelina, and also Rajesh Sharma made a visit to FIC once. So how did this, so I'm specifically talking about the mission that we had from Professor Novick. This was a study published by my supervisor, Sir Kamal Salim. So actually, he did the study in 2016, and he actually divided his results into 3 eras: before the program, during the program, and after the program. So on the next slide, you're going to see that. So it's like the Gora said, it's a busy slide, so I will not go into the detail of it, but just the brief of it, that over these 3 eras, the number actually increased from 1,000 surgeries in era A to almost 1,600 surgeries in era C. And the mortality, overall mortality dropped significantly. So there was statistical significance in terms of the number being done and the mortality which dropped. And also the RACS category actually increased in the RACS 3 and RACS 4. So the number increased in this category as well. Whereas in RACS 1 and the RACS 1 number dropped, and RACS 2 almost stayed the same. So, and the mortality also dropped for all these RACS categories, specifically talking about RACS 3 and RACS 4. So generally speaking, as I mentioned earlier, that this program was actually focusing on all the elements of the system. So it had a great impact on that system, and we then had a dedicated pediatric cardiac unit. Before that, it was kind of a unit like an adult surgeon doing both adult and pediatric. So after this program, we had a dedicated pediatric cardiac setup. And now coming to the second component, that international fellowships program, which me and my other colleague Intisar, we had an international fellowship program. So we both went to to Birmingham Children's Hospital for 2 years fellowship. So the next component is I'm going to talk about that how our visit going abroad made some change to the system. So that's I'm going to speak right now. So just speaking about the background of both of us, we did like MBBS 5 years at Army Medical College, then we had an FCPS general surgery with APHMI. Then we had the cardiac surgery FCPS program Definitely it's 3 years, but in FIC we spent 2 years in adult, 2 years in Paeds. During this time we did an FCPS, and then we went on international fellowship to Birmingham Children's Hospital. So, like over here, I'm doing the same thing. We have 3 eras: the senior surgeon, then we had a transition period when the senior surgeons were here, and we both junior surgeons were there, and then we have the junior surgeon who were doing independently. I mean, the senior surgeon had retired. So I have chosen. I have not gone into the RACS categorization. I have chosen some commonly dealt pathologies so that we know that how it changed during this time. So VSD repairs. So this is the graph of mortality. I'm specifically talking about mortality. These are numbers. The number remained pretty, pretty same. Apart from that, in the early 2043, they had higher numbers, but after that, we had this almost similar number. And the mortality, you can see the mortality dropped in the third era. But this drop was not statistically significant. There was a rise of mortality in 2017, and this was probably because at that time there was a sepsis breakout. I wasn't in that center at that moment. I was in fellowship, but probably because of the sepsis, there was a breakout of infection. There was a lot of mortality in the VSD category. In the tetralogies, this is the result. So this is the result we had in the previous era, then in the transition period, and this is in past 3 years since we both surgeons are working. So this drop in mortality was statistically significant. So we have now like top mortality of less than 10%. Glenn, again, this is one of the third commonest procedure done in our center. Usually the number remain almost the same. In the previous era, the mortality was high, quite high. Why? At this moment, in past 3 years, we have almost achieved a mortality of almost 0 or 1 patient in a year or something like that. The fourth, I was thinking about to choose between complete AVSD or supracardiac TPVR. So I just went for supracardiac TPVR. So for that, the mortality almost pretty much the same with it was not statistically significant. There was some drop in the peri-COVID period. I don't know what was the reason for that, but I mean, generally it has almost remained around 25%. Then coming to the ASO, and so I've taken all the ASOs in one category, ASO and ASO with VSDs. Why I didn't make that graph? Because the number is relatively small as compared to the previous procedures. So this is the general trend of ASOs done in our centers, in our center for past 10 years. So initially the mortality was quite high, then came the transition period, and in past 2-3 years, our mortality has dropped significantly. And I was talking in the previous session that the PDS stenting has a major contribution to our superior outcome in the past 2 years. So majority of these patients falling in this area are the patients who had PDS stents, and they were able to make out of the ICU. So Rastelli, I'm not talking about conduit surgery specifically. I'm talking about specifically over the TGA, VSD, PS anatomy. So almost no experience in initial 3 years, and started in 2017. In the past 3 years, we had a reasonable number of patients who had been offered Rastelli with mortality of almost around 20 to 30%. So since we did not have any Rastelli to take into account in the initial period, so we could just compare this small era. So this was not statistically significant, whereas the mortality which actually dropped in past 10 years for the switches, this was statistically significant. The Ross procedure, again, it started almost around 2018. Most of them were done in the last 3-4 years. We lost one patient because of bleeding. Rest, there's almost zero mortality with all the Ross we had. Fontan, my boss, Sir Kamali, was very fond of Fontan, so he had a lot of experience with Fontan. So you can see that the trend for Fontan has dropped. We are not Fontan lovers. We don't do Fontan that frequently. We do Fontans, but not that frequently as Sir Kamali used to do. But we have somehow achieved, although smaller number, but we have achieved a 0% mortality for the fountains. But this drop in mortality is not significant because the numbers on that side is quite high actually to compare with. So in the past 3 years, a few novel procedures that we have done with the mortality mentioned. Rastelli sending, we have done 3 Rastelli. We lost 2 of them. Both of them were actually in low cardiac output. One we had to put in ECMO, but he didn't make out of the ECMO. Then we have done 3 Nicardos. One that we lost was because of sepsis. Cone is something we are now working on. We have done 5 cones so far, 0 mortality in that. 3 Norwoods, lost all of them. We have also done some PA bands for the CTGAs with intact ventricular septum. We are doing good. I mean, I hope at some time we'll be able to offer them a double switch, but they are not at that moment. The LV is not primed well. And then we have done complex central PS reconstruction with Glenn, 7 patients almost. We have done hybrid VSDs. We lost 1 patient because there was iatrogenic injury with the guide wire. The cardiologist actually perforated the LV. We've done 2 hybrid Rastellis. By hybrid Rastelli, I mean the patient was totally dependent upon the one MAPCA. Both these patients were totally dependent upon one MAPCA. There was pulmonary atresia, dependent upon a MAPCA that was actually going from descending aorta into the left lung and then through the lung into the PS system. So if we had to close the MAPCA, the patient definitely would not have made it to the theater. So we actually had to do it on the table in the hybrid theater to close the MAPCA on pump and do a Rastelli. So at this end, we have done 5 ECMO runs. Only 1 was successful. That was a Bantal patient and lost 4 of them. And then we have increasing frequency with switches, Ross, Rastelli, and we are also doing complete AVSD repairs at much early age, at around 3 to 4 months at the weight of around 4 kgs. So our primary focus at this moment for our center is doing these procedures more frequently, Nikaido procedures, cone, and hybrid VSTs. So now, as I mentioned that we have 2 types of international training program. One is the international master trainer, which comes to the local institute. And then you have international fellowship programs. So what are the pros and cons? Now, definitely everything comes with its own benefits and definitely the cons of it. So coming to the pros of the first one. So in the international fellowship program, the international trainer, when it comes to your center, you are the primary operator. You are operating on the patient most of the times. They would be actually guiding you through, and it's more of like hands-on kind of a experience rather than just an observer status. Whereas exactly the opposite is the cone for international fellowship program, that most of the time you are an observer status. You get very less hands-on when you're working abroad. Then you're working in purely your own environment. You know each in and out of it. You know the staff from the IR to the top boss. You know how to work around, how to make your things work. So you exactly know all the small nuts and bolts of your system. Whereas in that system, you're quite alien. You take 6-7 months to actually understand what is happening around. Then you're dealing with your own patient population. As we all know, we all have worked abroad, that our patient is quite different from the patient which the Western communities see, which the Western physicians would see. I mean, our patient, we have late presentation, they're malnourished, they are septic, they have economy issues. So you have to keep all those things in your mind and then you treat the patient. Whereas in that setup, you have a totally different population. There is a broader involvement in the patient care because you're taking the patient from the clinic, operating, seeing him in the ICU, discharging him, and seeing him in the outdoor clinic after the surgery. So you're involved with the patient throughout his treatment pathway, whereas over here you have a very limited involvement with the patient. These programs are more system-driven. As I said, that they would come and they would actually focus on all the components of your healthcare, where over there it's very individual. You actually just focus on yourself. And they have no negative impact on your human resource because all your human resource stays here. Where on that side you have definitely your human resource has to go outside and actually they have to get trained from that side. So coming to the pros of international fellowship, you have exposure to a modern healthcare system, where over here you are not exposed to that, you stay within your own shell. So your exposure is limited by whatever you have in your system. Well, over there you see things in at a much better, bigger scale, in a much advanced way. So you actually know how a medical healthcare system should be working. You have superior academic activities. Over here, your academic activities are limited, like you can attend different conferences, you have exposure to different kind of seminars, you attend different workshops, you attend wet labs, so you actually have a lot of exposure when you're on the international fellowships. You see a lot of complex pathologies which are not a bread and butter in this part of the world. Most of these patients are denied surgery in this part of the world, but over there you see them quite frequently actually. And then you have a higher professional benchmark when you are working abroad. And it has no financial impact on your institute, whereas if you're inviting international master trainer, it definitely has a financial impact. You have to look for their travel, their lodging, everything. And some of them would actually definitely want them that you pay them from their services. You develop a good acquaintance when you are outside. And also you have a lot of fellowships options, international fellowship, whereas over here you have very limited options. There are very few programs who actually move around and going into countries like Pakistan where they would want to train that setup. So in the end, the recommendation would be that both of them have a positive impact on the system, just you need to know that what your institute needs. If your institute is something which is newly establishing, so you actually need more of international collaboration, you need team like what Dr. Munir has been leading, which should come to your center and which will focus on every component of your system. Whereas if you have a running system like we had, probably you would learn more from international fellowship. But it's not a hard and fast rule. Both of them, I think, should go side by side, and actually both of them would actually help towards your system. Thank you very much.
Invite the last speaker, Dr. Maham, who is going to talk about hospital resources and practice patterns for congenital cardiac surgery in Pakistan.
Assalamu alaikum everyone. My name is Mahi Malik. I'm a congenital cardiac surgeon in Rawalpindi Institute of Cardiology. I would like to thank the organizers and the society members for giving me the opportunity to present this talk. I do have a couple of disclosures. The first one is that this presentation was already presented previously at another meeting. And secondly, this is more of a personal disclosure that this survey was done at a time about almost a year ago from the time of this presentation. So what I present to you is a snapshot at that particular point in time. The good thing is that the field of congenital cardiac surgery in Pakistan is rapidly evolving. So some of that information may be different from what we see today. So we've been talking about this since morning, that CHD remains one of the most common birth defects and accounts about 50% of deaths due to non-communicable diseases. Generally, if you look at the mortality for CHD, it has declined by only 6% in the lower socioeconomic subgroup of countries compared to about 50% in the middle and the high STI groups. Within the LMICs, this CHD or congenital heart disease presents a significantly larger burden compared to higher and middle income countries. Unfortunately, the health priorities in low and middle income countries remain different, and CHD remains an ignored disease within those countries. Just to kind of give you a background of how important it is to talk about this, the incidence for Pakistan, according to the GBD study that was published in 2017, shows that the incidence is about 15 to 20 per 1,000 births in Pakistan. If you look at the number of, as one of the largest growing populations in the country, this presents a significant burden within our part of the world. Our mortality, you can see over there, pretty red, right? So we have one of the highest mortalities in the world. So again, CHD presents a significant burden for us within our country, and which is also why it's an important thing that needs to be addressed. So the purpose of this study was to collect certain reported data on how congenital cardiac surgery is presented in Pakistan. We conducted a nationwide study. The survey was designed by the research team. We did do a pilot study for understandability and accessibility of the survey and made our changes accordingly. The survey was distributed to all congenital cardiac surgeons in Pakistan. I can say this confidently because the group is small enough. And I was specifically, and as people in this room will vouch for that, I was specifically able to pester all of them to fill this survey out, and I think I did manage to do that for the most part. The survey tool had different areas that we tried to focus on. We started with surgeon characteristics, which was basically age, experience, training. We moved on to center characteristics, operative volumes, kinds of cases that were being done, available resources in terms of ancillary staff, as well as equipment, and then clinical practice patterns. We did our analysis with SPS. The second thing that we did in our survey was to try and estimate the actual disease burden within Pakistan. So we used this formula that was previously used by the IQIC study that was published in 2021 that also tried to estimate the disease burden, which basically takes into account the number of live births, which is of course calculated by the estimated birth rate multiplied by the population times 0.6, which is used as the uniform incidence of moderate to severe CHD, meaning congenital heart disease that requires an intervention. So this kind of excludes all other congenital heart disease which is followed and does not actually need an intervention. We included all centers with established congenital cardiac programs. We described established programs as the ones that had a formal program with pediatric cardiology, a dedicated pediatric cardiac surgeon. We did exclude centers that performed less than 100 cases a year. We also excluded centers that do not have any pediatric cardiology services available, and they're just independent surgeons that were practicing. And again, that kind of throws a few things off, but our focus was really on dedicated pediatric cardiac surgery programs. So looking at our results, we were able to, on our last count, we identified 17 centers within the country, which is actually a much bigger number than what I initially started off with. This one center in white is a center that's only active at certain parts of the year with foreign presence, with surgeons who come from abroad and operate. All other centers are the ones that have dedicated programs. As you can see, it's that Punjab, the most populous province in Pakistan, has the highest number of centers, and Balochistan over here, even though it's the largest province, has no dedicated, did not have any dedicated pediatric cardiac surgery programs at the time of this survey. So we sent out to 20 surgeons, 17 of which responded. We were able to get at least one response per center. We tried our best to maintain anonymity, but just based on the size, it is what it is. We did try to estimate our disease burden with what I said previously. So we estimated live birth. So our reported estimated live birth rate is about 26.5, and then this was the population at the time that we did our survey, multiplied by 0.6. So this is what it comes down to per center. So I'm going to take a minute and let this sink in. This is our estimated burden, the patients that will present per year at each of these 17 centers. That comes out to 2,200, on average, 2,200 new patients a year. So we're not talking about the ones that were previously diagnosed. We're not talking about the ones who were diagnosed late in life. This is just an estimate that's based on the number of kids that are being born per year. So 2,200 new patients per year per center, assuming that all 17 centers are at par and are able to provide those services. Moving on, so starting with the data that we collected through our surveys. So looking at surgeon characteristics, 8 of our surgeons were under 45 years of age, with 3 surgeons over 55 years of age. We asked about highest surgical qualifications, and we have a pretty good mix over here from 9 surgeons who were FCPS certified, FACS, and then UK and also Australia. We did ask about surgeons who had practiced abroad before coming back down to Pakistan, and 4 out of these surgeons had practiced at consultant congenital cardiac surgeons abroad. We talked about years in practice, and we did have a good mix. We had 4 surgeons who had been in practice for longer than 15 years, 6 surgeons who were under 5 years, and then the rest were in the middle. We asked about center structural characteristics. Like we said, the highest number of centers were in Punjab, which is also our most populous province. None in Balochistan, Kashmir, or Gilgit, Baltistan. Most of our programs were at government-owned or public sector hospitals. 4 programs were at freestanding children's hospital, with 13 which were a part of an adult cardiac surgery program. 11 out of these centers had designated congenital cardiac ICU present. The ICU ranged from a closed ICU, meaning it was run primarily by an intensivist, to an open ICU where an intensivist service was available. But for the most part, there was some kind of an ICU service that was available. Interestingly, 1 out of these centers had no supportive PICU or NICU. Most hospitals had a combination of either a pediatric ICU or a neonatal ICU present as well. Most units did have some kind of a step-down unit with monitored beds that were available. Looking at operative mix, we were unable to ask about exact volumes. So what we did was that we just put them in categories, and the purpose of this study was not really to determine volumes, because there was no way for us to verify that information. But 7 centers were pretty busy with greater than 350 cases per year. The rest were most centers were performing about 150 to 151 to about less than 250 cases per year. We asked about neonatal congenital heart procedures. We have a good mix. 4 centers were doing more than 50 cases a year. The most common CSG procedure in infants was VSD closure, which is not a surprise. The most common adult procedure was actually an adult tetralogy patient. So unrepaired tetralogy, we asked about this specifically, not PVRs, which is different from other parts of the world, was the most common adult procedure performed. Again, I think as surgeons, we're all obsessed with this BT shunt, so we asked about this specifically, and this is kind of what we got. Most centers were doing less than 10 cases per year, and probably happily. Moving on, we asked about neonatal procedures that were performed. If you remember my previous slide, 7 out of the 17 centers were doing neonatal procedures. Most common neonatal procedures that were performed by most centers were the top 4: coarctation of the aorta, pulmonary artery banding, PDA ligation, and BT shunts, which are all, we asked about this specifically. These were all done as closed heart procedures. The open heart procedures that were performed, as you can see, 11 centers were doing repair of total veins. 9 out of these centers were doing arterial switch operations, 6 were doing truncuses, and none were doing Norwood procedures, which I think is different from what Dr. Dawood just talked about. I don't think this is the time to talk about this. We asked about infant procedures. Most centers were doing BSDs, ASDs, and TOF repairs, as well as Glens. 12 centers were doing Fontan procedures. We asked about other less commonly done procedures, such as the Epstein's, Sennings, Rastelli's. The Sennings was a pretty interesting one, I think, just because we have probably so many late presenters who actually don't undergo arterial switch and have regressed LVs, which is probably why we're doing so many. Most centers were doing Sennings. And as somebody, actually Dr. Kamal Salim, your mentor, once said to me that Senning is just a glorified ASD closure. So,
That's my fault.
oh, that's right. So he's the one who said that to me. There you go. So no wonder we're all doing them and pretty happy doing them. And then what was included in this, which is neither here nor there, are valve procedures for rheumatic heart disease, which is not actually congenital heart disease, but a lot of that falls into the lap of the congenital surgeon because nobody else wants to do younger children. We asked about the services that were given by interventional cardiology at these centers. And these were actually, we were very happily surprised to see by how many procedures were being done by interventional cardiology at most of these centers. Some of this we talked about this morning, so pulmonary valvotomies, atrial septostomies, aortic valvotomies in neonates, PDA stents, RVOT stents, and then down here with the pediatric ones, ASD closures, VSD closures, and so forth. So I think this kind of, really, we were pretty happy to see how much work was being done by the interventional cardiologists as reported by the surgeons. So remember, this survey was only distributed among the surgeons and not the cardiologists. In terms of human resources, operative equipment, this is what we got. Most programs had dedicated anesthesia present. 13 out of those programs had in-house intensivists that were present. We just kind of wanted to see how things were going, and almost never over here for fast-track extubation in the OR. We do know some surgeons are big fans of those, and some programs actually do prefer doing those. Not going to take any names.
Out of the 17 programs reported in-house intensive?
Some kind of intensive care, yes. Yes. We asked if you have intensivists present in the hospital. We didn't ask specifically 24 hours, no. Yeah, no, we did not, so 24-hour ICU consultant coverage, no.
Intensivist service,
Yes.
whether or not.
No, we did not ask about that, no. So we asked a little bit about teaching and research, which I think was very important. Only 5 surgeons reported having congenital cardiac surgical trainees. Almost all surgeons reported rarely collaborating for any international research or academic activity. Most surgeons said that they had less than 5 active research projects at their center per year. And 3 out of the 17 centers reported having an international team of surgeons visit at least once a year. So again, like we talked about, we've been talking about in our session, research and collaboration kind of looks like to be lacking within the congenital cardiac surgery programs. We did some associations because our numbers were so small, we weren't really able to get, do a very complex data analysis. We did see, though, that obviously higher numbers were at the public or government-owned institutions. Intuitively, this is understood that freestanding children's hospitals did have better pediatric services, and interventional cardiology was pretty similar at the different centers, regardless of whether they were at a public-owned hospital or at a children's or at a private hospital. So I think there's a couple of things that that I'm going to talk about that this survey identified for us. And there's multiple limitations of this survey, and if I start talking about these limitations, that'll take longer than my actual presentation. So I think those are understood, but I do think that this gives us some important points. The first one is just volume. And just the disease burden that we have in itself makes CHD should be a national priority for us. We estimated 2,200 cases per year per center. I mean, that's just, there is no way, and if each center has 1 or 2 or even 3 surgeons, that's just impossible for us to do, right? There is no way that we can keep up with this. Compared to other countries, 1 is to 3.5 million, this is the surgeon to patient ratio. We're somewhere in the middle, probably not as bad as Africa, but nowhere near here is what we need. So what is it that we can do? I think this is what should be the actual discussion that should lead from this survey. The next thing that I wanted to highlight was the disparity within centers. The quality, amount, quantity type of work being done across the spectrum was just so different. And it was very difficult for us, statistically speaking, again, the numbers were what it was, so it's hard to get p-values and so forth, so this is purely a descriptive study, but the disparity was very obvious within those numbers also. There was a big difference in what was available at every hospital. And we talk about where we're at, and we talk about being in a low-income country, but again, the disparity and what we saw was just totally, it was all across the board. So again, I think this is also important because this should highlight things that should be done. And I think one of the most important things is public-private partnerships. All programs that have come up with some sort of amalgamation between public services and private equities or private resources have made these partnerships very successful, and I think some of the programs that have done this in Pakistan are aiming to do this in Pakistan will be successful. The other thing, and I was talking to Dr. Babar about this a couple of days ago, was this needs to become a national priority. This needs to become a priority for the government and for our national health program. And a couple of years ago, there was a lot of discussion about the NSOAPs or the surgical and the obstetric care program that was initiated in Pakistan in 2017, I believe. I think the plan was from 2020 to 2025, and the aim of this program was to decrease maternal and infant mortality, and unfortunately, CHD was not a part of this, and I think that was a big missed opportunity for us. We should have been a part of the NSOAPs and the National Surgical Care Program, and we were not. But I think this is something that we can actually advocate for and lobby for. So I think this is something that we should really, really look towards, and kind of, this gives us a point of reference for what we can.
Why weren't we a part? Politically, this is mentioned in one of our papers that we just recently published about why did this happen?
Next point, research and education. The need for congenital cardiac surgical training. I don't need to even go on about this because I will let Dr. Salman do it. But this is what we need. We need to have formal training programs. We need to have formal training. We need to have a degree. We need to have people focused on we need to grow more congenital cardiac surgeons within Pakistan. This goes, this is another thing that we seem to lose focus on, and some of that may just be that overwhelming patient burden that I talked about, is research and academics. And then again, to really make a meaningful study, we have no data. I can stand up here and say whatever I want and present whatever. There is no way of verifying or double checking or doing a fact check on anything that I've presented over here, because we just don't have that kind of data. And I think that's also very important. I picked this, and I don't know if you guys can see it, probably not, but I picked this from Dr. Babar Hassan's paper, one of my favorite papers actually, that talks about how to increase and how to get about to presenting contextual data from within lower and middle income countries without actually doing what the West is doing. And he comes up with a very interesting set where basically the aim for every program should be to provide contextual research for optimal CHD care. Like Dr. Daud Kamal talked about in his presentation, is that our patient population is different. The kind of the age we get, the kind of patients we get is different from, from where most of us trained. And we have no guidelines, we have no algorithms, we have nothing that pertains to our particular patient population. So I think providing contextual data is very important. How to go about it, I think all of you should actually read this paper. And this breaks it down into very concrete steps that can actually be followed. What interventions we need, what preconditions we have, what we should have to be able to get to this. And then as again, our assumptions, which were, so this is based on the theory of change model, and I could also go on about that, but this basically presents how you can achieve a particular goal that you've set and kind of work backwards and figure out how you're going to get there. And I think this is a very interesting paper for any program that wants to focus on its research and data. And again, the person who will lead us to the light and get us a formal congenital cardiac surgery program. Dr. Asim, aap dekh nahi rahe. All right, so I know I've been talking about all the terrible things that are the problems that we have and how awful CHD in Pakistan is, but I think there's some good things too. The first one is the robust interventional cardiology services, and I think that's very helpful and very important, and I think our cardiologists will be the ones who will help us achieve what we want to achieve. The next thing is that there's an increasing interest. So a 2016 paper that was published by IQIC that looked at the congenital cardiac surgery services in Pakistan counted 7 centers. My study counts 17. So that's a pretty good number to have grown within in less than 10 years, I think. And I think the interest in congenital cardiac surgery is growing in our country pretty rapidly. And as I started, when I collected that data to today, I think it's, the landscape has already changed. It's evolving that rapidly. So I think this is something that we should really kind of strike on while the iron is hot, I would say, and really use this as a point to really grow our field. And then the really good thing is that our surgeons are young. Right? Right there, exactly. So I think that's another opportunity, right? To have a group of surgeons that are young and are committed and are ready to kind of, do what they're doing. As you saw, Dr. Daud present his results, and regardless of what he got up here and he did it. We did that last year when we met in Lahore, and I think those are things that would really help us grow. So I think this is another opportunity that we should utilize that will really help our field to grow. So some of these things I've talked about already, and I'm just gonna very briefly touch upon them, is this public-private partnerships. I think this is the vision forward that would really take congenital heart disease to the next level. We saw a slide earlier from this. This is another paper I would recommend everybody to really read. I have the citation right here on how Kerala really turned their CHD program around with the plan, the patient care continuum that they implemented, and how they managed to really decrease their infant mortality by identifying and directly referring infants and neonates that were born with CHD. Again, need for collecting contextual data and audits, and we talk about this within our group and to each other about how we need to come up with some kind of a database, be it a national database or be a part of an international database, but somehow we have to collect this data and be able to analyze it objectively. And then, of course, formal training programs, and we talked about this. What can we do international and national collaborations with twinning? So one program partners with another program. Dr. Munir talked about this also for really capacity building and growth. Thank you.
Is there any questions for the 3 presentations? Okay.
Can I go first since I have to run for another one? No, if there are any questions.
He has question.
Thank you very much. Everybody, the presentation was an excellent one, honest, straight out, was a good one. From this standpoint, okay, the big question, 17 centers. Should everybody Satara IQIC में शामिल हो जाए? Yes.
Yes.
इसके ऊपर अगर एक agreement है सारे then that should be a clear thing. Then if we do that, do we need to have a national database?
I don't think we need to reinvent the wheel like we talked about it. I think being a part of the advantage of being part of an IQIC is that you get almost apples to maybe a little better apples than we have. but pretty close to apples, and not apples to oranges if you were part of SGS, let's say, or some other, the high income group country. So I think IQIC provides us with contextual data. And having used the IQIC database in the past when I was at AQ, and we at RIC are now enrolling again, and hopefully by January we should start enrolling our patients into it. It's very easy to use. It's very easy to get that data in. I do like Daud's idea of having some national context also. And I think the easier way, instead of trying to set up our own database where verification of data is going to be very difficult to do, is to combine that data, right? So we could make our own registries with specific procedures or specific pathologies, and then take it from there. But I do think, I think हर एक होना चाहिए. I mean, short answer. Absolutely. बिल्कुल.
सेंट्रल हेडक्वार्टर कमेटी हो जाए, सारा डाटा वहाँ चला जाए, ठीक है, होगी, keep it blind, don't disclose mortality, otherwise you don't need to disclose mortality.
But
क्या numbers तो आ रहे हैं, आना तो शुरू हो, लेकिन
But what is the use of that data? So if you are just collecting numbers, it is meaningless.
well,
right?
so better point कि data आपने collect जरूर किया है कि यानी data में आप mortality दे, होगी, keep it blind, but that then start guide you कि resources कहाँ लगाए, कितने
But वो sensible होना चाहिए ना? Yeah, IQIC data.
You have to go.
we're going to go, and it's very easy to enroll. We're doing that process, and we just had to fill a bunch of forms. Right. And it's not hard to do.
Let me hear Daud, because he's already on IQIC, and you still want to develop another database.
IQIC का देखिए the advantage with the IQIC is कि एक तो you have a developed system, वो आपके system आपके data को analyze करते हैं और they compare it against all the other centers जो register हैं LIC के साथ. लेकिन उससे हमें ये पता नहीं लगता जो मेरा इंटरेस्ट है शायद, और in times to come ये हम हमारे बाद जो सर्जन आएंगे उनका इंटरेस्ट होगा कि पाकिस्तान में लेट्स से टेट्रोलॉजी, पाकिस्तान में इन 17 सेंटर्स ने टोटल कितनी टेट्रोलॉजीज की, उनमें से कितने बच्चे 1 साल से छोटे थे, कितने 1 साल से 5 साल के दरमियान थे, कितने 10 साल से ऊपर थे, और हर ग्रुप में ओवरऑल मोर्टेलिटी कितनी थी. ठीक, हमें वो एक चीज जो ट्रेंड है कि हमें अपने मुल्क का जो पेशेंट पॉपुलेशन है और हमारे अपना कंबाइंड आउटपुट है उसका हमें इससे आइडिया नहीं लगी हुई.
IQIC के अंदर है. And then you can have breakdown कि टेक्नोलॉजी कितने की है, एज क्या थी, everything is there. And the thing is that we as a unit man, I mean pediatric cardiac services, need to be mature, be beyond our egos.
Exactly.
Right? Problem that we have been brought up in a society that is including everything under this, not this roof, under this hotel roof, is to protect our egos. The only thing being sold over here is how good I am, and refer the was I am the king of everything, right? We have to be beyond that. We need to understand that we can only progress if we learn from our weaknesses and other strengths, and the other person should be there to provide you that strength and protect you. That is my thinking of being in a society.
I think being an adult cardiac surgeon sitting in a congenital session, just wanted to say one thing. I have worked in the UK and being a consultant and worked here as well. You know, the biggest challenge for any data here is validation. It shouldn't be about our ego. It shouldn't be about our results or frowning on somebody's mortality or even an individual prerogative. It should be just a frank data. But how to validate it, that is an extremely difficult problem to sort out in Pakistan. That's what I have seen.
So there are two methods of validation. One is internal, where you have got your own systems developed that you validated. And then you have got an external validation which will be provided by the IQIC. So IQIC designates a center and then sends people over there. Initially they used to come themselves, but it became too expensive for them. So now they send people which are associated with IQIC. So I have come and validated AFIC's records. AFIC has come and validated AKU's record when there were only these two centers on the IQIC forum. But as we grow bigger, we will have more variety. And the beauty of validation is that he doesn't know which files I'm going to validate and which aspects are going to be checked. Right? So yes, validation is, without validation data is useless to an extent, but even without validation you can still have some guidelines as to what your data is showing. I mean, I'm not criticizing anything, just picking up a point that your tetralogy of fellow mortality is 10%, right? So now you have got to think as to when you were in Birmingham General Hospital, what was that tetralogy of fellow repair mortality? Maybe it was 2%, maybe it was 20%, right? So if it was 2%, why was it 2%? And that is the target you are going to set. So that is how data will change the outcomes in the future.
I want to यहाँ से हम उठ के 17 सेंटर हैं. All 17 have to be an IQIC by how long will it take?
The next meeting.
1st January, sir.
Next meeting, I mean, and we need to have one focus.
How will you know that? So is there a way to check okay, which centers are on? नाम आ जाते हैं ना उनके. हाँ.
वही कहना कि हम इधर से उठे 17 सेंटर हैं, हमें पता हो कि एक बंदे का काम है कि तुमने 17 बंदों की जान खानी है कि तुम IQIC के ऊपर तुम्हारा सेंटर आ गया कि नहीं आया, और अगर नहीं आया तो क्यों नहीं आ रहे.
हाँ, एक चीज होती है,
वरना तुम हम में से नहीं हो.
I think we need to just talk. अगर कोई एक बंदा, like if you take this opportunity. चलो, we can ask anyone.
सारे सेंटर अगर IQIC पे आ जाते हैं, then automatically हमारा database बन जाता है. जो पिछले ये 10 साल पहले मीटिंग 2013 से ही बात की थी. अभी आप ये देखिए कि वाइन ने प्रेजेंट किया है, every center was an IQIC. This would have been an ordinary
हाँ.
that cannot be ambiguity.
It's a good goal for the next meeting. Majority centers are.
They should come. नहीं ये नहीं कि वो लोग हो जाए. They should come and present their IQIC data. Asif, you wanted to add on something?
When I see you talking amongst yourselves, it's a deja vu again. In 1988, there was a meeting in Bristol. All the 15 cardiac centers went there. The concern was the mortality for complete atrioventricular septal defect. A chap called Wishart, who was a consultant there, he said, what we will do is write down everybody's mortality, all surgeon specific, and we'll put in a basket, my secretary will pick out the lowest, whoever, we won't know whose mortality is what, we'll pick out the lowest mortality and we'll identify who that lowest mortality is and we'll go and try learning from that person. So nobody knew what the mortality was. This is a true story, I'm just telling you how it was. They picked out, there were all sorts of mortality. There were 50%, 75%, 100% mortality. I'm talking about 1988 now. There was one person whose mortality was 2%. So pick up that, Bill Braun. All the surgeons, I'm telling you because I was a registrar there, all the surgeons came weekly to learn from Bill Braun. That's what happened. That's how things change. Nobody knew whose mortality was what, but they all came to learn from him. So I'm just telling you, all you're talking about now, what is the aim of all that? You know, personally we have lots of aims. Personal ambition, money, improvement in our prestige of our institution, prestige of our province, all that sort of thing happens. But all that you can achieve, the only way you can achieve is by getting better. You know, you can achieve all that by collaborating. United you win, divided you fall. Because, you know, sort of the whole group, 17 centers, you all want to do better. You shouldn't be. Because if you, all your thrust is patient-centered, patient-focused, and I know when we started medical college and before, we all think that we have great plans and we'll do good in the... But as some journal said that all the plans of a battle all disappear on the first contact. And we have had lots of contacts, yeah? Because we lose track of all this, you know. At the end of the career, well, I am reached now. I never think of how many Norwoods I did, how many Nikaidos I did. You know, double switches I did, how many transplants? I did 400. But I don't care about any of this. That does not affect me at all. I don't sleep well just because I think worrying about, you know, sort of, oh, I should have, maybe I've done 20 Norwoods, I should have done 50. Then I don't give a shit. What I think of is what good I've done. Your history is written by your juniors. If you don't treat your juniors well, they are going to write your history. Your legacy would be by the trainees. So that's all I have to say. Collaborate on things which you can collaborate. You'll all move forward. It will do you good. सुन तो सही जहां में है तेरा फसाना क्या कहती है तुझे खल्क खुदा गायबाना क्या. You know, that's what you need to do. That's my message to you.
एक क्विक सा बस एक रिक्वेस्ट है कि एज वी आर कलेक्टिंग डेटा खासतौर पे आएगी और खासतौर पे जो इंटरनेशनल टीम्स आती हैं, प्लीज डेटा इज योर्स. पेपर छप जाते हैं, किसी का नाम नहीं होता है हमारे यहाँ का. ये जो सॉरी टू से फर्स्ट पेपर ऑफ IQIC दैट वाज पब्लिश्ड डिड नॉट हैव अ सिंगल ऑथर फ्रॉम AFIC, जबकि AFIC वाज द फर्स्ट पायलट सेंटर ऑन इट. एंड इट इरिटेट्स मी कि ये सेंटर हमारा पाकिस्तानी डेटा लेके आपने छाप दिया उठा के उसको. So please, one of the things, especially with AI, because when we start collecting data, all these companies will come, the foundations will come to get that data, and make sure that you write it in your contracts. कि नहीं भाई, जब तक कि हम primary authors नहीं होंगे, first author, end author, and grant हम PIs होंगे, तो फिर होगा, वरना नहीं.
At a deadline, like January 1st से they should all start rolling. ताकि वो हाँ कि जी 1st January से they should start enrolling.
बस just a few comments to add. अभी currently पेशावर में सिर्फ 9 centers हैं, they are doing congenital surgery सिर्फ पेशावर में. And the volume varies between 200 say 400 and 100 different ones. It's a lot of volume, and none of them are collecting the data we should. So the reality is far more than, and the patient volume is far more. Adult congenital इतना ज़्यादा है, हम उसे Like last week alone, I did like 6 cases in just 1 week of adults, 17, 18 years old patients. So it's a complete different picture. So I think the majority data आए तो हमें we'll know more about what's happening in Pakistan and we can make meaningful decisions on that.
Actually, the data will surprise you. लोग हमें समझते हैं बहुत बुरा कर रहे हैं, हम लोग बहुत अच्छा कर रहे होंगे.
जी.
और जो समझ रहे हैं बहुत अच्छा कर रहे हैं, बोले ये क्या निकला? Right? And there will be
I
there
did-
will always be room to improve.
हाँ I did वो नबील हमारे साथ था. 2017 से हम अपनी सारी सर्जिकल डाटा we are putting in database and I think by now हमने कोई 15 या 20 papers publish कर लिए. What we do is every year सारा डाटा कलेक्ट करके पब्लिश कर देते हैं. It's mostly for our own learning. like हमें comparison मिलता है जो आप कह रहे हैं, which is very important. I think that's the first step कि डाटा हो, आप इंटरनेशनली कंपेयर करें, नेशनली कंपेयर करें, तो उसके लिए डाटा डालना is the first step. So we are doing it very good.
अगर आपको वो analyze हुआ हो सारा data,
Even better, even better.
validation बहुत ज़्यादा
And what we can also circulate, inshallah, is we'll circulate the standardized Excel sheets for you guys.
That will be easy. You don't have to do that.
You can just populate it, like drop down menu.
बस we'll
Bana diye.
Babar will lead us and then we will हाँ
Send it to you guys.
मैं और सलमान इस पे काम कर लेंगे. ठीक है.
Thank-
And beauty is that at SIUT, the IQIC data, surgical data, is governed by a cardiologist. And yeah, so it doesn't have to be a surgeon, right? हम लोग overwhelmed हो जाते हैं, यार मैंने data डाला.
I think we need to hire somebody who is specifically trained. क्योंकि with data guy, we need to have a data guy, na? Because the surgeons do not have time. Residents are already overwhelmed. We will add. Okay, Salman, I think we should move on to the next part of the session because there are 3 papers. There are three more talks.
Then you can back
So then we can, yeah. So let me introduce the next 3 papers are free papers, and the first I am going to invite Dr. Waleed Shahzad from RMI, who is going to talk about outcome and trends of surgical VSD closure in a tertiary hospital in Pakistan, retrospective study. Waleed.
Bismillahirrahmanirrahim. My name is Dr. Waleed Shahzad Ali. I am a final year resident cardiac surgery in RMI, and today the topic which I am discussing is outcomes and trends of surgical VSD repair in a tertiary care hospital in Pakistan. So let's come to the brief introduction of our topic. Actually, VSD is an opening in the wall separating the 2 lower chambers, that is the right ventricle and the left ventricle, and it is among the common congenital heart malformation, divided into perimembranous, muscular, inlet, and conoventricular or doubly committed type. Incidence across the world is 0.1 to 0.4% in newborns have VSD, while in other congenital anomalies, it is considered around 29%. Management always based on the symptoms, the size of the defect, the severity of the complication, and the procedure which we done is the surgical closure or either endovascular closure. So the objective of my study was to study the demographics and outcomes of VSD repair, and total 78 patients were taken, and it was a retrospective study from 2017 to 2021. Data was taken from our cardiac surgery database, and only those patients were included who had congenital VSD, isolated VSD, and who underwent open surgical correction, while other patients who had concomitant complex cardiac anomalies like coarctation of aorta, TOF, transposition of great arteries, tricuspid atresia, and truncus arteriosus are excluded. So patient was diagnosed as with history and examination and a transthoracic echo by a Paeds cardiologist. And our intervention was recommended based on the multidisciplinary team discussion with a pediatrician, a Paeds cardiologist, and a surgeon. And then the patient was selected for open versus device closure on international recommendation. And different techniques were used for different types of the VSDs. Like for perimembranous and inlet VSD, we use transatrial approach, while for doubly committed, both transpulmonic and atrial approach with patch using either interrupted or continuous patch sutures. So if we look at the results, so we divide our patient in 5 age group. The first is who are less than 2 years, while the second one is preschool 3 to 5 years, the third 6 to 12 years, teens 13 to 17, and more than 17 were classified into adults. And we have seen in our data that most of the patient, that is 26.9% patient, were presented in their childhood, which is 6 to 12 years. Majority of them were male, which is 62.8%. Patients were also divided on their BMI, and it has been seen that maximum percent of the patient, like 49.2%, were presented in their healthy weight, while significant amount of the patient, like 35.6%, were underweight also. Among 78 patients, 46 were divided in NIHA class. They are more than 6 years of age, and 52.17% patients were in NIHA class 2, while 17.39 and 8.6% patients were presented in NIHA class 3 and NIHA class 4 symptoms. So following are the operative characteristics which were seen in our study. So the hospital days, stay days were almost 6 days. ICU stay were 45 hours. Perfusion time is 69 minutes. Cross-clamp time is 41 minutes. Mechanical ventilation time post-operative hours were 3.57 hours. And the patient who received blood intraoperatively is 66%, and those who received blood post-operatively is 16%. So there are following complications which were seen. So one patient reopening because of the bleeding tamponade, while one patient had more than 24 hours of prolonged ventilation, while 9 patients had prolonged hospital stay, which is more than 7 days. And 3 patients had prolonged ICU stay, which is more than 48 hours. One patient came with deep sternal wound infection, and inpatient mortality is 1.29%. So this study shows acceptable results of the VSD surgical closure in our center, and it also showed that there is the diverse age of group of patients which came with VSD, but majority were present in their childhood. We also compare our study with the other study which was held in Pakistan, and another study which was done in Karachi shows a mortality rate of 3.4%, while studies which was done in the higher income and developed countries have either no mortality rate or very low mortality rate, which is less than 1%, while studies which is done in lower income and developing countries show the mortality range from 1 to 3%. It is being seen that age below 5 years was associated with adverse outcomes, and those infants, those who are whose age is less than 6 months, and they have low birth weight, for every kg decrease in their weight have 1.84-fold increase in their complications. While there is another study which also found that the weight less than 10 kg and age less than a year is also related with a high post-operative surgical complication. So I am concluding my study with that surgical repair of VSD is a safe procedure with low mortality rate, and we have seen that the majority of the patients were presented in the childhood, but there is a significant percentage which is presented in the adulthood also, and less than 50% of the patient had a healthy BMI. Thank you. Any questions?
Questions will be at the end. We'll move on to the next one. We are going to invite Dr. Zishan Abdul Nasir, who is from Peshawar Institute of Cardiology. Determinants of major adverse events and complication after surgical VSD closure in children weighing than less than 20 kg. Dr. Zishan.
Bismillahirrahmanirrahim. Assalamu alaikum. Well, my presentation is not that catchy like the ones before me, and I certainly can't present like Sir Munir Sahab or Sir Asif Hassan Sahab. But I hope I'll reach there someday. I hope, inshallah. So Waleed has made quite an easy job for me because my study and history is almost the same. So I have no financial interest, arrangement, or affiliation that would constitute any conflict of interest. So introduction, Waleed did most of the part. VSD was first described by Dalrymple in 1847, most common form of congenital heart disease, and its incidence is increasing in Pakistan with 4 to 6 per 1,000 live births. The objective of my study was to study the major adverse events like post-op residual VSD shunt more than 3 mm, complete heart block needing a PPM, unplanned second operations or reoperations for bleeding, post-op pulmonary artery hypertension, sternal wound infection, organ dysfunctions and complications like neurological complications, respiratory complications, and renal complications, or renal failure that would require temporary dialysis. And the secondary objectives were associated complications like prolonged mechanical ventilation, more than 24 hours, prolonged ICU stay, more than 2 days, and prolonged hospital stay more than 7 days. This was a retrospective study from a single center in Peshawar Institute of Cardiology from October 2021 to March 2022 within a duration of 6 months. After that, we had to shut down our OTs because of the infection rates that Arif talked about this earlier. So all patients having isolated VST was included, and those who were less than 20 kg. Exclusion criteria was patient having major cardiovascular anomalies like TOF, double outlet RV, pulmonary atresia. A total number of 52 patients were included in this study. Since it was a pilot, so kind of a small study. The male were 59%, almost 60%, and the female were 40%. The mean age at the time of surgery was 2.79 plus minus 2.60 years, with less than 32% less than 1 year, 44% 1 to 5 years, and 23% more than 5 years. While the mean weight at the time of surgery was 9.74 kg plus minus 4.78. We segregated it into less than 10 kg and 10 to 20 kg. So 67% were less than 10 kg and 32% were in 10 to 20 kg. The type of VSDs that we studied were, well, according to the STS classification, type 1 were 9.6%, type 2 or perimembranous were the most, 78.8%, type 3 were 0, and type 4 muscular were 11.5%. Trisomy 21 syndrome, Down syndrome was present in 3 patients. Pre-op RV hypertrophy was present in 2 patients. Previous PA bending was done in 1 patient. The type of VST repair, primary closure was done in 13 patients, and patch closure was done in 39 patients. While autologous pericardial patch was used in 9 patients, and Dacron patch was used in 30 patients. The mean cross-clamp time was 31.27 minutes plus minus 11.97, and total bypass time was, the mean bypass time was 58.96 minutes. So the incidence, this was the peri-op or the major adverse events were studied during the first 7 days basically. So during the first 7 days, we can see that there was 0 residual shunt, 0 reoperations, renal dysfunction was observed in 0 patients, and post-op pulmonary hypertension, the post-op PICO was usually done in ICU, observed was 0. Sternal wound infection, 1 patient, she was a Down syndromic patient, and she had 1 patient needed PPM for complete heart block, 15 patients had respiratory events, mostly pulmonary arterial crisis, and 0 patient had neurological events. While 15 patients or 28.8% patients needed prolonged ventilation, 6 patients needed prolonged ICU stay, and 3 patients needed prolonged hospital stay. The various variables, various factors like age, weight, they were compared against the major adverse events and the associated complications, and a p-value was obtained by Mann-Whitney test, which is usually used for small data. In age less than 1 year, we can see the p-value is quite significant for major adverse events, prolonged ventilation, prolonged ICU stay, and prolonged hospital stay. while in age 1 to 5 it's significant with the prolonged mechanical ventilation and ICU stay and hospital stay, while adverse events were not as significant. While more than 5 years of age, they were not quite significant. Gender had no significance, male and female, no significant value. Gender had no association with the complication or study. The weight less than kg showed significant association with the major adverse events. You can see the p-value is less than 0.05, and weight more than 10 kg showed no significance value. The p-values are high. The type of VST or the total cross-clamp time, bypass time had no effect on the major adverse events or complications in our study. We compared it with other studies which were done across the world. In their studies, bypass time was quite associated with the complications and major adverse events. Given their sample data, their data was quite high. RV hypertrophy, there was no significant value with RV hypertrophy, while trisomy 21 syndrome had p-value of less than 0.05. And so, with conclusion, surgical VST repair is safe with low mortality, age less than 1 year, and weight less than 10 kg had quite a significant impact on the major adverse events and associated outcomes. Gender, type of VST, bypass time, RV hypertrophy had no significant impact on outcomes in our study, while trisomy 21 had significant values for outcomes. Limitation, this was a retrospective and observational design study, limited number of patients, it was a single center study, and study on larger scale across the countries needed. Thank you.
Thank you very much, Zishan. Now I will invite Dr. Rabia, Sayyida Rabia. She is going to talk about Kono's root enlargement techniques. Follow-up report from PIC Lahore.
I'm Sayyida Rabia from Punjab Institute of Cardiology. I'm currently a senior registrar there. We had actually done a few cases of conorest and root enlargement, and I'm happy presenting this. That or video answer चलेगी? Okay. So all of these cases were done by Professor Aftab Yunus. Actually, I've included these definitions for the juniors, but I guess most of them are not there. So why we need aortic root enlargement? Aortic valve replacement can be complicated by a small aortic annulus. So we have often to do root enlargement. Mostly it is done posteriorly. We have a series of 88 cases with posterior root enlargement, and a very few in very few cases we needed the anterior root enlargement to avoid prosthesis patient mismatch. In addition to use of low profile prosthesis. So it's an important adjunct to AVR in patients with very small annular size. It improves patient prosthesis mismatch and improves the patient's functional outcome. But it is underutilized due to fear of mortality, morbidity, longer surgery times, and a learning curve. Dealing with the conorostin, it involves a longitudinal incision in the aortic root and a transverse incision in the right ventricular outflow tract, which makes a straight line. And then 2 pericardial patches are used to close the aorta and the RVOT respectively. We had 12 cases in 5 years. Most of them were DVRs. We had done DVRs with Kono's root enlargement 5 cases, AVR with Kono's 1, and DVR with TV repair along with Kono root enlargement 2 cases. And then we had an AVR along with Kono's root enlargement, and we had to do a pulmonary valve repair in 1 case. And there was a 9-year-old boy who had a PDA ligation in addition to AVR with Kono's. And we have to do septal myectomy in 1 patient and septal myectomy with BHD closure in 1 patient along with this anterior root enlargement. And early mortality was a bit high. It was 16.6%. 2 of our patients out of these 12 died shortly after the surgery. but rest of them were at regular follow-up till 6 months. We lost 2 patients during the first 3 months, after 6 months, and after 12 months, only 4 patients are at regular follow-up. None of other could be traced. This is the cause of mortality. We had a VSR in our patient immediately recognized after on first post-op day with an echo, but before we could get time to fix it, we lost the patient. We were initially doing continuous technique with the septal patch, and then we switched our technique to interrupted pledged sutures for the septum, and the other patient had an intractable VT. So these are the implanted valves at aortic position. Most of our patients are adults with the smallest one was 9 years old and the eldest was 40 years old. So we had to had a larger implant. 19 mm mechanical St. Jude valves were 3. With Onyx we had done 3 routes, and in 5 patients we had implanted a 21 size St. Jude, and only in 1 patient we had the privilege to use this Medtronic low pivot valve, which had excellent results. So median sternotomy was the approach for all the patients, and we did ascending aortic cannulation and the single cannulation in AVR and bicaval in all DVRs. And we always use a combination of antegrade plus retrograde cardioplegia. This is the echo, post-op echo of our patient, which shows increased gradients across the. Isme pointer, which shows increased gradients with a mean gradient of 29 across the aortic prosthesis. But we had done a DVR with TV repair, but we couldn't fix the TR. Patient still has severe TR with severe pulmonary hypertension and impaired RV systolic function as well. This is another patient. The echo was done after a few days of DVR, and you can here see the gradients which are minimal, and there is no valvular or paravalvular leak or vegetation, and intact interatrial and interventricular septum. So this is other patient, and I want to discuss the pre-op and post-op echo. And these are the gradients of this patient pre-operatively with the gradient 78, and post-operatively these were reduced, and there was no in the interventricular septum was intact, and the patient is continuing his life routinely. This is another patient. We had observed increased gradients post-operatively after the procedure during this follow-up. His initial post-op echo was fine, but now he has increased gradients. Previously his LVOT gradients were 85, and now he still has raised gradients due to less mobility of the one of the disc of the prosthesis. These are the CT films, and you can here see this was the patient with a VSD, whose VSD was fixed along with this technique, and she also had a normal post-op course, and she also had to have a normal pregnancy afterwards. These are the post-op CT scans of other 2 patients. With anterior root enlargement, we can clearly implant a larger prosthesis. We had a patient with annular size of 14 mm, and then we implanted a 19 mm St. Jude mechanical in this patient. So this was actually meant for the residents. Here, this is the incision, and then they taught me along with the extension. We have to extend our incision just behind the RCA. Just behind the RCA, from the right coronary cusp into the RVOT. And this is the defect created after incision, and then we are going to close it. This is the Paro picture of the patient. This is aorta, and this one is septum, and this is RVOT. Orientation is a little different from the pictorial representative. We use two patch technique, in which, and this is the first patch, and this is the lower half of the patch, which closes the defect in the interventricular septum. And this upper half is reflected onto the aorta for closure of the aortotomy. And this second patch is used half. This area is discarded, and only the upper half is left, which closes the RVOT. I'll show you in the next slide. This is the first patch. These have used interrupted stitches. We have done a few cases with continuous stitches, but afterwards we have shifted to interrupted stitches for every case. This is the first patch. After we had stitched the first patch up to the level of the aortic annulus, then are we going to implant the aortic stitches, and then we make a new annulus with these two patches along with plagiated sutures from outside. Here you can see the plagiates running from the second patch, then through the first, and then out through the valve on the new annulus we have made on the septal defect. So it's the final orientation of the annular stitches, and this last stitch has to be placed one needle through the patch and the other through the normal aortic rim. So this is the pictorial representation, and this is our per-operative picture. You can here clearly see the implanted aortic valve with the stitches in place, and this is the RVOT with the patch to close it. So finally these two patches are stitched together. This is the final picture. This is the patch, the first patch upper half which closes the aorta, and this is the second patch, the upper half, which closes the RVOT. And in our case, this is the first patch closing the aorta, and this is the patch on the RVOT, as the picture first was taken from the head side. These are the post-op images of these patients, and you can clearly see the valves, CT images. In this post-op CT, we can here identify the aortic patch, this one, in this patient. And this seems to be RVOT patch, but it has not clear demarcated like that in aortic region. This is the level of the aortic valve. This is another CT with this being the aortic patch. This is the image of the patient which has reduced disc mobility. You can clearly see that one disc is not opening well. This is the female patient with the low pivot valve, and she has continuing her life with excellent results. So these are again the CT images pointing. This is the disc which has reduced angle. We have that's why we had raised aortic gradients. I would like to play. Just play. Okay. ये वीडियो सही तरह से नहीं चल रही है. This is the aortic. You can clearly see the aorta is of small size, and then this is the incision into the RVOT. This is the incision being carried in the RVOT, and you can then clearly see the RVOT from inside. आवाज़ कम नहीं हो सकती? पता नहीं क्या क्या चला होगा। सही है। ये मेरे लैपटॉप पे आवाज़ नहीं आ रही थी, तो इसलिए मुझे खुद भी याद नहीं है कि क्या क्या बोला हमने। This is the subaortic membrane. This is the subaortic membrane dissection of one of the patients. Here is the subaortic membrane. You can clearly see below the level of the valve leaflets. Yes, this is I am pointing towards. Okay, this is a septal myectomy. We had to do because because the increased septal thickness of this patient. We have resected a wedge. This is the same patient with the subaortic membrane, and these are images of the same patient. So you can clearly see a wedge being resected from the septum. Okay, this is the first pericardial patch. You can here see we have implanted interrupted stitches, and then we are going to implant the new annular stitches here at this level. Okay, these are the aortic stitches being placed from the rest of the annulus. This is video of another patient. We have couldn't complete a video of a single patient, so we had to do it in bits. This is the RVOT patch being stitched of the second patient. Okay. You can see the disc movements in CT of this patient. Then the patient with the reduced opening angles. And then in the third, you can clearly see the two discs moving in the CT. So milestones achieved by patient. 2 kids from South Punjab are back to school. 1 patient passed his matric exam after surgery and presented to us with sweets. 1 female patient started job, and the last patient had a normal pregnancy after surgery, and her kid has turned 1 this year. Yeah, this is the patient with, yes, all of them were mechanical. This is the patient who has the increased post-op gradients, but he is symptomatically doing well. He now plays cricket as well. तो वो खेलता है ना, उसको कैसे रोकेंगे? ये साउथ पंजाब से था. So अब उसको जो भी मिल रहा है, तो सर नहीं सर, ये मतलब नहीं है कि डॉक्टर इरफान बोलना चाहते हैं इस पे. सर पेशेंट को बहुत मुश्किल से ट्रेस किया हमने. उसके पास जो डायरेक्ट नंबर था वो भी उसका नहीं था. मतलब आप उनके फाइनेंशियल वो देख सकते हैं. So these root enlargement techniques are technically demanding and had a steep learning curve. We had expectations to reduce mortality in future. Most of our cases were DVR with severe pulmonary hypertension, and that's why I think they had lost to their follow-up. Most effective in extremely small annulus. So done with open heart surgery. Do not forget to close. This is the video of the theater after we have implanted 2 patch. This is the aortic patch, and this is the RVOT patch. You can see the stitches here, some of them reinforced with interrupted stitches. Again, you can clearly see the big heart here. I think patient selection is likely to improve the mortality. We should avoid doing in high-risk cases. Okay, this is the kid of the last female patient. Okay, thank you.
Thank you very
Any
much, Dr.
questions
Rabia.
you would like to ask?
Let's start with you because you are the last presenter. Any
Okay,
question
Salim.
from the audience? Then,
Why did you choose this chrono technique? Why not posterior root enlargement, especially in adult patients?
So we had been doing posterior root enlargement. We have done 88 cases in PIC Lahore. These all of these patients whom were selected had extremely small annulus. The annulus was of 14 mm size, 15 mm size mentioned on echo. That's why we have chosen the anterior root enlargement. Where we always have in our mind to do a posterior root enlargement if we find a good annulus peroperatively. Sometimes there is a discrepancy between the annulus mentioned on echo because most of the patients are not having preoperative CT. Many of the patients. You can see. ये कैसे चलेगा? ये शो करना जरा, ये जरा चलाना दोबारा. हाँ जी. अच्छा ओके सही. Most of them had
any question?
Yes, sir. Yes, sir. We have implanted 21 St. Jude's.
And you had a sub-valve
हाँ जी, 2-3 में.
My question, Dr. Aftab, that in such candidates, if the pulmonary valve is okay or normal, then the ideal operation is ROS. So, don't do ROS there, or? अच्छा. अच्छा.
तो अब आपको अजीब लगेगा कि मैंने कोनो YouTube पे जाके देखा.
नहीं
कैसे होता है?
YouTube is also one of our great teacher. I see Nikaido when I start doing it, I watch it on YouTube.
तो रॉस तो मैंने ना कभी किसी को असिस्ट किया ना कभी देखा, तो मेरे लिए नहीं.
तुमने देखा था वहाँ रॉस? नहीं.
आप करते हो आप करते हो,
बाकी सब देख लिया.
जी जी, मैं अपनी लिमिटेशन बता रहा हूँ ना, मैं आपको अपनी लिमिटेशन बता रहा हूँ ना.
नहीं, that's fair enough because I think at that point.
So we are adult surgeons basically.
और मैनेजमेंट पहले दिन से लेके कब्र के 80 साल के बाद तक आ सकती है आपको.
करनी पड़ सकती है.
Sir,
And my second question was that what I have seen and I learned that not just one technique can upsize or root enlarge. So you can do a little bit of Nix, little bit of cono, little bit of posterior. So, every surgeon tries to do the best for the patient and try to put the biggest valve possible. If you can do it from 15 to 19, that's a great. But if you want to go up further, then you can add more techniques. So just cono alone is not sometimes sufficient.
मुझे क्वेश्चन होगा कि कोनो का जो इंसिजन एओर्टा पे आप लगा रहे हैं, ठीक है?
हाँ.
जो मैं लगा रहा था वो डिफरेंट था, उसके साथ पोस्टीरियर वाली एनलार्जमेंट कैसे करेंगे?
नहीं, उसके लिए पता है, मैं just I was taught always to divide the aorta and then do it because it comes right in front of your face and it's much easy and then you can go in any direction. Avoiding the bundle, avoiding the coronaries and placing not just one patch, you can place one patch there, one patch there, and you can increase. Because in your limited short-term follow-up, the trans-valve gradient increased because it was 19. So 19 has an inbuilt gradient, and then over the period of time, it is likely to increase. And in those part of our country where they are not very compliant with the medicine, they are not taking warfarin, their valve will be stuck very early.
We recently, before coming to the conference, we had to see a patient who called Sir Aftab for a decision regarding she wanted to study cardiac perfusion. And she told Sir that she has not been taking warfarin for 4 years and she was a DVR.
सर वो DVR plus aortic root enlargement है.
They're scary.
It's scary. It's scary. उसका INR करवाया 1 है, लेकिन उसका valve अभी stuck नहीं हुआ. Gradients थोड़े से बड़े, दोनों valve उसके चल रहे हैं.
Lucky. You know, sometimes luck favors.
हाँ जी, करवा के आए हैं सर, आते आते. Yes sir. She couldn't be followed at a government institute that we are somehow lacking the communication between the gynecologist and the cardiac surgeon, so we had to operate at a private setup where Professor Aftab was performing duties. So we had her pregnancy, we had असल में हमने उसको मना किया हुआ था कि भी आपने नहीं करनी, पर she somewhat conceived. तो वो पर नहीं, वो हमने उसको ऐसे ही मैनेज किया था क्लैक्सिन पे, और फिर उसके बाद
जब उसने मुझे बताया तो मैं कहा कि आपको मना किया था. शी सेड कि जी अब क्या करो. आई सेड कंटिन्यू, आपने वार्फरिन बंद नहीं करनी, चलती रहेगी. लास्ट वीक में आके वार्फरिन बंद की थी, उसको हॉस्पिटल एडमिट करके. जैसे ही उसका INR 2 से कम हुआ था, 2 से उस पे हेपरिन इन्फ्यूजन पे थी, और गायनेकोलॉजिस्ट से था कि जब इसका INR 1.5 से कम होगा आपने इसका सी सेक्शन करना है. हम ज्यादा देर वेट नहीं कर सकते कि जी अब 2 दिन के बाद करना है. उससे कोलैबोरेट करके तो लेके आए थे गायनेकोलॉजिस्ट से. वो उसने मुझे
वो लेट बताया था उसने.
6 वीक्स या 8 वीक्स पे बताया था उसने.
Teratogenic effect.
उसकी डोज रिलेटेड है. डोज रिलेटेड है.
अच्छा.
अच्छा, न्यू गाइडलाइंस में 5 मिलीग्राम तक, हाँ जी, इज अलाउड.
लेकिन 5 मिलीग्राम पर तो INR आता ही नहीं है यार.
मतलब
इन 20-30 kg.
सर वो अभी
ग्रोन अप चाइल्ड की बात
सर, ये अभी इस वक्त भी आधी गोली ले रही है. मतलब मेरे साथ अभी भी उसका फोन पे होता है, व्हाट्सएप पे वो भी है कि उसने जी अब उसका
वो भी कभी लेती है कभी नहीं लेती.
नहीं लेती, इसे लेती है. अभी उसका INR 2.7 था अभी जो उससे लास्ट कराया. वो आधी गोली ले रही थी, तो मैंने उसको यही कहा कि आधी गोली कंटिन्यू करो.
चलो, okay.
Low profile.
I think we should move on. Is there any question for Dr. Zishan?
मैं बताना चाह रही थी.
जब लो प्रोफाइल लास्ट वाले में किया है तो उसके ग्रेडियंट्स मीन सिंगल वो सबसे कुछ प्रेगनेंसी और चीज.
सर वो जो पोस्टीरियर रूट एनलार्जमेंट का आप क्वेश्चन पूछ रहे थे, वो हम उनका नॉर्मोग्राम जो एओर्टिक वेल्व का है ना, अकॉर्डिंग टू बॉडी सरफेस एरिया, हम उसके मुताबिक ही प्लान करते हैं पोस्टीरियर रूट एनलार्जमेंट अपने पेशेंट्स के लिए. थैंक यू.
Okay, is there any question for Dr. Zishan from PIC, who talked about post-op morbidity, major adverse events post VSD? Dr. Zishan? No question? Any question for Waleed regarding his talk? Okay, so that concludes our session. Now I think I will request Dr. Asif to hand over the certificates and shields. Dr. Asif is sitting board, so I would like to invite him. Overview, yeah.
Thank you for asking my opinion. I'll be kind. The wonderful presentations, and I think the techniques in all three, the VSDs, the Racono, are exemplary. I mean, Kono, I saw most of the operation I saw at AFIC when I came many years ago, and the surgeons who were doing, they were doing in adult, I mean, I was really astounded how many Konos they did at that time. So, and your technique looked brilliant, you know. In terms of, I made my comments in the last, for your last, and I think I have to emphasize that you have lots of common problems, and I think your major common problem is procurement of homographs. You lack that, and I think maybe a subcommittee from your institutions, all of them together, can make some representation, and I would urge you to go to Narayana or get information how you can do it, because I think that will improve your, reduce your costs and improve your quality. And some of the problems you are encountering in terms of limitation of Ross procedures or getting RV endocarditis will reduce. I mean, that will be wonderful. But in addition, there are so many collaborative things you can do. I was pleasantly surprised and really happy how the infection side of things was talked about, you know. And the reason was that Tariq came up and said, this was my problem. We messed up. The sympathy you get when you tell everybody that you've messed up is much better than you say, no, I've done this and I can do this kind of work, I can do this operation, and how good is my results, and that generates antipathy. That generates antipathy. Trying to promote your own self just generates antipathy. I think you need to be humble and accept what you do wrong is much more important than what you do right. Failure is the biggest teacher. If you fail, that's your biggest learning point. It's not to get depressed because something happened and the patient died, but what you learn from that, it will save another 10 lives. So I think that's my basic message, and I've said all the emotional things beforehand. I don't want to repeat them.
Okay, now I think I was just told that we have to distribute these shields since morning, the presenters. Half of them are gone, so those who are available, let me invite Dr. Munir Amanullah. He's the first one, please. को पकड़ कर देते रहा आप एक उठा No, he is one of the speakers this morning, so he came here to me. Dr. Ijaz.